I'm also on the board of the MDS Foundation, which is located in Crosswicks, New Jersey, near Trenton, but is an organization made up of, well, it was founded by doctors, and its board is pretty much all doctors except for one lawyer and one accountant. Everyone else is a researcher or somebody who has spent their life working with MDS. And some nurses too. We have 2 nurses on board. I'll just say what my situation is very quickly, and then you can go around and tell us who you are, introduce yourselves, and just to let the doctors know where the patients are in the process. So I was diagnosed with MDS by this man in 1998, and I immediately needed transfusions, and they were 1 month apart at the beginning. I took Revlimid and Vidaza. I took the growth Neupogen and Epigen or whatever, that's Aranesp, I think it's called now. Now I'm getting transfused about once every 8 days, 8 to 10 days. And I'm still hanging in here. So that's who I am. Go ahead.
We're sisters. Our father is an MDS / MPN patient, so he has a combination. Initially, the first few years, the doctors were telling us he has MDS, but more recently he has more of the 2. But he definitely has low hematocrit, so he started doing injections April, about 2 years ago.
A year and a half now. He was diagnosed 2005 first, and he started getting the injections like a year and a half ago. But the past summer, the symptoms of anemia got worse, so he started getting transfusions. At first it was like every month, a month and a half, but as the time passed by, he started getting transfusion every 2-3 days last November, and then the new medicine came out, Jakafi. So he
more
for the myelofibrosis.
Oh, okay, yeah.
It's a new medicine, so he's in that new medicine right now. Since he had a large spleen at that point, and since he got to this medication since November, he's now getting blood transfused every 3 weeks, and he saw better results after this medication, but that's all.
But
My name is Fran Boyles, my husband Joe. I was diagnosed in '06 with RARS MDS, and I've been through Revlimid and Aranesp and Neupogen and Vidaza. Some of them worked for a while, but now I'm on transfusions. I've had 34, and they're not so bad, except antibodies and stuff like that.
Right.
And the taste of XJ.
And the XJ makes me extremely tired, and so much so I didn't take it the last 2 days because it's tired of being tired.
And how often are your transfusions?
Every 2 weeks.
Every 2 weeks. Thank you, I remember you. Thank you for being here.
And thank you for having I appreciate it.
Thanks.
My name's Kent Bachman. I'm 56 years old. This is my son Ryan, who's my half match in bone marrow transplant. Last April, May, in my database, I was going down, turning white, and we have a friend who's a pathologist technician, and she noticed I was not acting well. My wife didn't notice it, turned white, and went to see the doctor and took some blood, and my blood levels were extremely low. So then that pushed me over to a company in Harrisburg called Andrews & Patel, and I have a very nice doctor named Catherine Baruka, bedside manners, and I am very grateful for that. And she gave me some injections for the growth hormone. Nothing happened. I was on weekly transfusions. I had 24. So that's 24 times 2 bags, you know. She got me into a clinical trial at Johns Hopkins under the care of Dr. McDevitt, who was very much the opposite of Dr. Baruka. And he told me not to read the internet anymore, because I kept asking, you know.
How can you not, though?
Well,
It's easy for them to say, they know it.
You were so right. And I explained to him, I said, no.
That's what I was told too when I first started.
I said, you know what, and I'm an engineer. And I said to him, I said, you don't have this disease. I'm 56 years old and I'm not liking the numbers I'm looking at, like 5.7 years to something, and I was like, you know, something's not making any sense to me. But what we found out was I must have had this for 10 years. And every time I get a physical, my blood numbers were always below the normal low levels. And it wasn't until recently it really plummeted me. So I've been taking oral Vicdaza. I am now in remission basically, but they tell me that it won't last. And they're pushing very hard for a bone marrow transplant. And Ryan's a half match, so I'm looking that around too. Because I don't like the terms and conditions of the Johns Hopkins bone match. Something a little closer. You have to live within an hour's drive to the hospital, and you have to be here, you have to be there. And they said it's his policy, and I like policy, but policy means it could be broken.
Yeah. Are you close to the center in Danville in Bucknell, near Bucknell? There's a hospital,
Geisinger, yeah.
Guys, no, I'm a stone's throw away from Hershey Med Center.
Hershey, yeah.
So I have a March 20th meeting with the bone marrow transplant physician, whose name I don't remember. I'm going to see what's going on there. I didn't know half matches were a good thing. So, and it scared the living hell out of me. That's my story.
My name is Pat Thompson, and I don't have too much to say. I only got diagnosed like a year ago, and right now everything's okay. Like, it's just a watch and wait thing, which drives me crazy because, you know, you wait and wait and you don't know.
But you haven't needed transfusions yet?
No.
That
When
lasts.
do you need them? Like when your blood count would get to like below 9 or?
Yeah.
9?
Or when you have symptoms. Some people can go a lot lower.
Yeah, there's no magic number. I mean, obviously you were
Oh,
white
yeah.
as a ghost and had very low numbers, and you were still functioning on some levels.
Yeah, the fatigue was my greatest.
Yeah.
You know, because I would be working and all of a sudden I would fall asleep. You know, and it's just a little scary. Then I was like, one thing that threw it off was my office is a flat line from the parking lot. It's only 100 yards. From when I parked the car to the front door, I was out of breath. And I was like, my gosh, I'm 55 years old. I gotta get in shape.
Yeah.
That's what I felt too.
You know, it's scary. Your heart's like, so.
Except I was 48.
40.
And I was a swimmer, and then I just couldn't do the laps. People that I used to pass were
Yeah.
passing me, and I said, this is terrible. I gotta go see a doctor.
So once, you know, patients sort of know what's going on with the red count, they sort of, usually they tell us sort of when they think they need a transfusion. We don't always just go by the number per se.
I even got a Hickman. Yeah, yeah. And that was, I have to tell you, with all the transfusions, I was black and blue. You know, this is actually not a bad thing.
Well,
See,
we
my
have,
daughters didn't want me to come today because they kept saying, now you're going to hear all kind of stuff. But I like to read everything. I just want to know, you know.
sir,
Well, I was diagnosed in 1997.
your name was?
Bill Shulevitz
Okay.
from New York City. My doctor was a very fussy doctor, and I went to an annual exam, And he said, you know, he says, you're very slightly anemic and you've never been anemic before. So go take iron pills. Did that for 3 months, came back, same thing. Said, well, the MCV is a little high, try folic acid. So I took folic acid for 3 months, I came back, same thing. So he sends me to a hematologist who took a bone marrow sample from my chest, breastbone, I guess. And I felt good. I didn't know I was sick. I had no notion of feeling sick at all. And the anemia was just very slight. This guy comes up with the MDS diagnosis and he says, look, your hemoglobin, your iron levels are abnormally high. The ferritin was about 700, which is high. So he said, you got hemochromatosis and I'm going to treat that. And I had 4 phlebotomies. Each phlebotomy, the hemoglobin started going down, down, and then I did feel sick. And I said, this guy's going to kill me. So I found a doctor over at Sloan Kettering, Dr. Berman. And I went to see her and she said, well, you may have hemochromatosis, though I doubt it, but I'm not going to treat it. I'm going to treat the MDS because it's more serious. And the iron levels have increased very slightly since 1997. And I've never been treated again with a phlebotomy. I'm feeling very good. I've never had a transfusion due to MDS. I've had some surgery and I've had transfusions in the surgery, but never due to MDS. I live on EPO, and now I'm taking EPO about once a week. But, for example, this last week, if the hemoglobin is too high, they won't give me a shot, and that happened last Friday. And I'm feeling good. I'm 80 years old. I work every day.
Great.
And I'm feeling pretty good.
Yeah.
At Sloan Kettering one day they decided, well, we're not going to give EPO anymore for people like you. They just walked in one day and there it was. So I called up Dr. Silverman, whom I'd met, and I thought he would, and he does. And that's why I went to see Dr. Silverman.
His nurse is on the board of our foundation, Erin DeMacos.
Which one?
Erin DeMacos. Have you ever
Never
met her?
met
She's an assistant that works for him. Is that
Erin.
Erin, E-R-I-N.
Oh yeah, I met her, right.
Right.
Yeah.
What's the medicine that you're on?
I'm sorry?
What's the name of the medicine that you're on?
Right now I'm taking RNS.
Oh, and that takes care of it for you?
I take it once a week. Some weeks the blood's too high. They got a rule about the blood. If
You're
it's too
lucky it
high, they don't
works,
give it
yeah.
to me.
So out of curiosity, what number do they withhold? In
12
New York
is the-
State,
12
it's different by
is the
state.
limit.
12? That's,
Yeah.
wow. That's probably higher than Pennsylvania.
It is.
Yeah. So this,
It's apparently a little questionable because a lot of people in New York just won't do it. For example, Sloan Kettering wouldn't do it.
mm.
And when my blood level goes down without RNS, I really do feel lousy.
How low do your levels get?
Without RNS,
Yes.
they get down to about 9.5. And at 9.5, I can't work anymore.
And then you take the RNS and they go back up.
Yeah.
9.5 would be...
We kill for 9.5.
I'd be out dancing at 9.5.
9.5 is what I aim to after a transfusion.
Maybe you get used to it. I don't know. When I get to 9.5, I'm an investment manager. I just can't think when I go to the office. It just, my mind gets tired. It just starts on about something and it gets too tired
That's
to
part of it.
follow through.
Blank out.
Yeah. And that's why I was a partner here and worked 125% of the time. And now I work 20% of what I used to do.
Yeah, I can
Because I
imagine.
get tired after a couple hours.
Yeah.
And then I'm afraid I'm messing up things that's not fair to anybody if I can't concentrate. And that's, so. Okay, well, we have 2 physicians here. Who's going first?
Mike is
I'm going first.
Okay,
So,
well, Dr.
yeah.
Michael Millenson,
Right.
and from Fox Chase Cancer Center.
So I'm at Fox Chase Cancer Center in Philadelphia, and thanks for sharing all of your stories. So I'm actually the director of the hematology service at Fox Chase, and I actually deal with a lot of different hematologic malignancies, MDS being one of them. But I also work with the NCCN, the National Comprehensive Cancer Network, guidelines committee. And so we actually meet a couple times a year to go over guidelines for management of MDS. And we try to keep things updated. There's actually a website for the NCCN. And actually it reviews guidelines for basically all cancers, but also blood cancers, including MDS. So for those of you who are internet savvy and who want to, actually, with your doctor's permission, go on the internet, this is, a useful site. But these are, so what I was going to do, I wasn't quite sure, where everybody was in terms of where they're coming from, in terms of your knowledge of MDS. So I was going to basically give a 3-slide overview of MDS so we're all kind of on the same page. And then spend time talking about the issue of iron overload. And for this disease, we're talking mostly transfusional iron overload, although it's interesting, you point out that you had hemochromatosis diagnosed. There's actually a gene test for that.
The gene test was negative.
Yeah, so you probably didn't have the hereditary iron overload syndrome, hemochromatosis. And we'll talk about, I think there are some misconceptions about the fact that you can actually have high ferritin levels and be iron overloaded with MDS, even if you've never had a blood transfusion. There's something about that we don't fully understand, iron absorption in patients with MDS. So that's a common misconception. So I'll diverge and talk a little bit about iron, the iron cycle in humans, and how it's absorbed, where it's distributed in the body, and some of the potential adverse health effects of iron overload. And then we'll talk specifically about the issues with MDS, how much iron's in a unit of blood, how much transfusion do you really need to have to be concerned about iron overload. And then we'll talk about the evidence in terms of, does iron overload really affect outcomes with MDS? How important is this as an issue? And then we'll segue to Dr. Pemberton's part of the talk, where he's going to review the indications for starting on iron chelation treatment to try to lower total body iron stores, and some of the drugs available, and this whole debate about when do you start, should you start, how critical is this in the overall management. So just by way of overview, you're all, I'm sure, pretty familiar. You're students of the disease. Some of you have had this for a long time. Some of you are more recently diagnosed. But so basically, this is a heterogeneous group of disorders characterized by abnormal bone marrow stem cells. And these are the cells that are kind of the mother cells that mature and produce all of the blood cells in your bone marrow and release the cells into the bloodstream. And the bone marrow stem cells are abnormal in these disorders, and it results in just impaired manufacturing of blood cells. And so this can affect one or all 3 cell lines. So red cells, white cells, and platelets. Low red cells meaning anemia. So you're all sounds like you're familiar with the consequences of low red blood cells, with fatigue, breathlessness, sometimes lightheadedness, fuzzy thinking, and so on. But also the white cells can be low, so there can be an increased susceptibility to infections. Platelets can be low, so we have concerns about increased risk of bleeding. And these are considered so-called clonal disorders, so meaning that there oftentimes are one or more chromosome abnormalities that are seen with these disorders. And this is thought to be tied into the biological tendency for these disorders to transform to leukemia. So there's clearly an increased risk of leukemia, and the risk is higher if you have higher risk MDS. So it sounds like some of you are familiar with the International Prognostic Scoring System, or IPSS. And this was devised, I guess, by your good friend Dr. Greenberg and company. So this is already from 1997, and this takes into account the three variables you're all familiar with. So the bone marrow blast percent, these are the very immature cells that are potentially leukemia cells in the bone marrow. The karyotype, or the chromosome profile, and then the number of the blood cell lines that are affected, whether it's just the red cells or also the white cells and the platelets. And we sort of, assign a value to each one of these three variables and then come up with a total score, and that sort of segregates MDS into the different risk categories from low, intermediate, 1, intermediate 2, and high. And that seems to be a good way of separating people into lower risk and higher risk MDS. And so for the purposes of this talk, the issue of iron overload, iron chelation, we're mostly focusing on patients with low-risk disease. I mean, that's the population of patients with MDS where this is an important issue. And so, so the different risk groups sort of, give us different goals of treatment depending on the risk group. So I think for all risk groups, one of the main goals of treatment is clearly to maintain quality of life, supportive care measures, and clearly this is where transfusions have a very important role. But also, preventing and treating complications. So in particular, mindful of issues like infections and bleeding if the white count and the platelets are low. And obviously treatment to correct the low blood counts, transfusions for red cells, drugs like Aranesp and Procrit to help stimulate the production of red blood cells. There are some drugs I'm not going to cover that are in development for trying to raise the other counts. I mean, obviously there's Neupogen, these other myeloid, so-called myeloid growth factors to try to raise the white count. There are drugs that are being tested to see if they raise the platelet count in patients who have very low platelet counts. And those aren't really commercially available already from prime time outside of clinical trials. And obviously, one of the goals is to try to prevent progression to higher risk disease or acute leukemia, and that's where treatments like Vidasa and Decogen come into play. And obviously, one of the goals clearly is to prolong survival and to attempt cure if possible, and that's still, in this era, the main treatment for attempt at cure is bone marrow transplant, which obviously has a very complex calculus in terms of risks and benefits. So, so obviously red cell transfusion is one of the mainstays of supportive care for this group of diseases, and pretty much all subtypes of MDS. And we talked a little bit about the so-called transfusion trigger. What's the number where this becomes something under serious consideration? And I think everyone in this room probably has a different number at which they become symptomatic. And we often, when we see patients, we kind of figure this out on a case-by-case basis. Some patients do fine when they're in the 8s or even the high 7s in terms of their hemoglobin level, but when they drop down into the low 7s, suddenly they can't walk up the stairs, they can't breathe normally. And there are other patients where if they drop below 9.5, they're symptomatic. And so we try to figure this out for every patient that we manage in terms of what's the transfusion trigger. And clearly, quality of life is clearly improved. Many patients tell us they feel great after they get their transfusions, especially in the early going. For patients who've been on transfusions, for a very, very long time, I get the sense that maybe there's a little less oomph, when they get a transfusion. So the decision really is based upon symptoms and individual patient circumstances. And so the problem is that each unit of red blood cells contains somewhere in the order of 200 to 250 milligrams of iron. And I'll go through the iron cycle to put this into perspective a little bit. So the whole subject of iron distribution, the iron cycle, is something that we all sort of learn in medical school, but it's not something even doctors think about very commonly. But it turns out, so iron is a very carefully regulated element in the body. And this is a cartoon from a review article from the New England Journal of Medicine from Nancy Andrews from some years ago, but it's still a nice cartoon because it's pretty simple. So this shows you that the main source of iron intake is obviously in the diet. And this is a little cartoon of an intestine, so your food comes through the GI tract, and small amounts of iron are actually absorbed. The average is about 1 to 2 milligrams per day. And it's then sort of transported and distributed in a variety of tissues around the body. So a lot of iron obviously goes to the bone marrow, where it's necessary for producing red blood cells. And so about 1,800 milligrams of your total body iron, probably total body iron is somewhere in the neighborhood of 3 or 4 grams. So 1.8 grams is in the bone marrow. And then a lot of it goes to muscle. So there's a protein called myoglobin, which is also an oxygen-carrying protein where your muscles need oxygen for metabolism. But then a lot of iron actually goes to storage iron. And the main organs for storage are the liver, number one, but also the immune cells, the macrophages. These are the cells that chew up iron cells, and so a lot of iron is actually present in those cells. And then a very small amount of iron is actually lost each day just from the normal wear and tear of the lining cells in your intestine. So it turns out, you lose lining cells that are growing old and senescent in your GI tract, and those cells have some iron in them. So there's, on average, again, it's about 1 to 2 milligrams of iron lost just by normal wear and tear of the cells in your GI tract. So there's a very careful balance here. 1 to 2 milligrams absorbed each day, 1 to 2 milligrams excreted under normal circumstances each day. And it's important to point out from this cartoon that there's no arrow that sort of implies that there's a natural way for the body otherwise to lose iron. So there's no physiological mechanism for getting rid of iron. And that's important in the context of MDS and transfusion iron overload. No way of getting rid of iron. So this is just another cartoon from the same review article showing that there are a variety of mechanisms that actually regulate the amount of iron that's absorbed from the GI tract. And I'm not going to get into the scientific details, but the point here is that under certain conditions like MDS, there's actually enhanced iron absorption. And this is why patients probably can become iron overloaded, high ferritin levels, even before they have their first transfusion, that they're probably absorbing and storing iron at abnormal levels. And this is just showing you the iron cycle. So one of the major regulators of how much iron is absorbed is a protein called hepcidin. And that seems to regulate how much iron is absorbed, how much is stored in the various tissues. So there's something about patients who have certain disorders, MDS included, where the hepcidin mechanism is somewhat impaired and it allows for increased iron absorption. So there actually are lots of causes of iron overload other than MDS and transfusions. So I mentioned just now the increase in gastrointestinal iron absorption. And this is a list of some of the things where this is seen. At the top of the list, hereditary hemochromatosis, which we not infrequently see patients who are erroneously labeled as having hemochromatosis when they really have MDS. That's not so uncommon, but hemochromatosis is actually a very commonly inherited disorder. It's one of the most common genetic inherited disorders. And so there now are very good genetic tests that can be done. But typically, patients with hemochromatosis, when they're first diagnosed, we wouldn't necessarily expect them to be anemic, but they certainly are iron overloaded. Chronic liver diseases, hepatitis, cirrhosis. There is this interesting description of increased dietary intake. The African Bantus who use these iron pots for their cooking, and there are well-described cases of iron overload from diet. But for a normal Western diet, it's actually very hard for people to eat their way into iron overload, because your intestine, if you have normal regulatory proteins like hepcidin mechanism and so on, you're just not going to absorb it under normal Western diet circumstances. So for the purposes of this talk, the main concern is transfusion iron overload. And so at the top of the list is congenital anemias, thalassemia, which is very common in certain parts of the world. And these are generally children with severe thalassemia are often diagnosed in infancy or childhood. And they often can be transfusion dependent from very early in life. And so this population of patients historically has been the population where we focused a lot of time and interest on the whole topic of iron overload. And as it turns out, a lot of the chelation studies have actually involved children and young adults with thalassemia and iron overload from thalassemia. And so we'll probably, Dr. Pemberton will get to this issue of a lot of the data we have to sort of extrapolate with these iron chelating drugs from the thalassemia population. And there's actually less data in MDS. But refractory anemias, aplastic anemia, MDS, for the purposes of this talk, is certainly on the list of transfusion iron overload. So when we monitor patients with MDS, there are several laboratory tests that we like to follow and to monitor to assess for iron overload: serum iron concentration, the total iron binding capacity, or TIBC, the transferrin saturation, with the normal being up to about 50%. And then the serum ferritin. So this is the storage protein that's a reflection of, can be a reflection of total iron stores in the body. Again, normal's up to about 265 in most labs. It sounds like from going around the room that we've heard some numbers that are much higher than that, and that's typically the case in patients with MDS. So we look at these, mostly the serum iron, the percent saturation, and the ferritin, those are actually pretty reliable ways of sort of screening for iron overload. There are other ways too, though, I'll just briefly mention some of the imaging techniques that have been used. Again, a lot of this comes from the thalassemia population. So these are people who've been transfused for their entire lives, hundreds and hundreds of units over a period of sometimes decades. But this is an MRI scan of the heart, actually. This is so-called T2 star imaging. And this is sort of a cross-sectional picture of the heart. So this ring is sort of the left ventricle of the heart, and this is the right ventricle. And this doesn't project very well, but you can sort of appreciate that on the T2 star images, the lower panel on the right side here, the heart, the ventricle muscle is very dark, and that's often the appearance when there's significant iron overload of the heart tissue. So this is somebody with very mild iron overload, intermediate, and then very high iron overload. So there are some centers that actually have expertise in this. I'm not sure that there are any centers in the Philadelphia area.
Oh, I do it at CHOP.
Do you? Yeah.
So I have an MRI every year at CHOP for my heart and my liver.
Yeah. So again, that's something that, again, it's a CHOP because of the thalassemia connection. So again, a lot of this data comes from from the Thalassemia Pediatric. So this is because sometimes the iron levels and the ferritin levels in the blood can be a little hard to interpret. This is another way of monitoring to see if there's deposition of iron in the tissues. And so you mentioned you can do the liver. Also, it's the same idea. This is somebody with, these are sort of cross-sectional MRI scans of the abdomen. So this is sort of like the patient's lying on their back. This is the liver here. This is the aorta and the spleen on the left. And so this is somebody who has very mild iron overload. This is sort of moderate iron overload. So you can see the liver is sort of darker. And this is somebody with pretty severe iron overload. So the liver is extremely dark looking, much darker than the spleen. And this is somebody who has significant iron overload. This is a sort of a modification of the T2 star technique. This is the so-called R2 relaxation phase MR assessment where you get these nice colors. And it's the same idea. This is a normal liver. This is mild, moderate, and severe iron deposition. And there are ways of actually quantitating this based on the spectrum. But it turns out this correlates actually pretty closely with the actual iron content if you were to do a liver biopsy, which nobody relishes having their liver harpooned. But this is actually showing you the R2 values plotted against the actual measured iron content from a core biopsy of the liver. They actually can take a little core piece of tissue, chop it up, and measure the iron content. And so the MR actually correlates very nicely, as you can see. So I don't think anybody does liver biopsies so much anymore. But MR is actually a nice way of doing this. So I guess there are occasions when we consider doing this kind of testing. It sounds like you've been getting this done. I don't know if this is something you do with other patients very commonly.
Not commonly.
I would say, it's not something that I've personally done a lot, in my practice. So the issue really is, when do you start to get concerned about iron overload? I mentioned that each unit is 200 to 250 milligrams of iron. And again, comparing that to 1 to 2 milligrams absorbed from the diet each day. So obviously, 1 unit is a pretty huge dose of iron. So if you're getting 2 units at a time, that's 4 to 500 milligrams of iron. If you're getting them every couple weeks, you can do the math. It's really significantly more than you would get with diet. So the question is, does iron overload affect outcomes with MDS? And this is actually from a review article, but the original data was from Dr. Malcavati and the group from Pavia, Italy, where they sort of collated their experience with 500-odd patients with MDS, looking specifically at this question. And in their analysis, they actually showed that the overall survival was actually worse in patients who were transfusion dependent, and that applied to pretty much all risk groups of MDS. And so their data suggested that indeed there is an influence in terms of transfusion dependency. And the question is, this was a retrospective study, the question is this because patients who are getting a lot of transfusions have high-risk disease, or they're sicker in some way? And I think the problem with a lot of the data sets is that they are retrospective, and it's hard scientifically to sort out how much of this is really directly attributable to the transfusions themselves. Obviously, transfusions are a necessary part of the management. So this group also looked at serum ferritin, and the hypothesis was that some of this difference in outcome was attributable to the iron story and concern about iron overload. And what they found, they defined iron overload as a ferritin of greater than 1,000. Again, normal being up to about 265. And they found that most patients, on average, they reach this threshold after about 21 units of red cell transfusions, and the median time to exceeding the level of 1,000 was about 11 months. So again, if you're getting 2 units a month, 10 months, 10, 11 months, somewhere in that range. So when patients become transfusion dependent, this number of 20 units and a ferritin of 1,000 seemed to be the threshold beyond which there was a concern about effect on outcomes. And so what they found in this analysis was once you exceeded 1,000, for every 500 above 1,000, there was a worse or inferior survival, and the statistics was about a 30% increase in risk of actually death from higher ferritin levels. And they also found that this was most apparent when they looked at the low-risk MDS subtypes. So these are, the subtypes RA and RARS, where, patients are often transfused for years and years and years. We've heard stories in the room today about this. And so this, again, seems to be this is the biggest issue for patients with the lowest risk types of MDS. We're getting transfused over a period of a long time. This was a different analysis. So this was actually presented and published by Stu Goldberg, who's at Hackensack. He used to actually be down at the Fox Chase Temple bone marrow transplant program. So he has had an interest in this area, and he with his colleagues, looked at a Medicare database, trying to tease out, effects of transfusion and potentially iron overload on outcomes using a very large database. So the Medicare database is sort of like, looking at medical care from 30,000 feet. I mean, you can get sort of, from looking at Medicare claims, you can get some idea of, what patients with MDS, what other kinds of diseases they're submitting Medicare claims for. But you really can't get very detailed, drilled down data in terms of specifics of patient outcomes. But when they looked globally, this analysis had about 512 patients with MDS compared to 1.3 million control patients. And what they found was that there was a higher incidence of cardiac events. This was things like congestive heart failure, cardiac rhythm disturbances, and it was very highly statistically significant difference. They looked at diabetes, and again, 40% versus 33% higher in MDS patients. Liver disease was a bit higher, but certainly pretty rare by comparison with cardiac events. And sepsis, which is a severe infection syndrome, was higher in MDS versus control patients. So the implication from this was that maybe there's something about MDS patients, maybe it has to do with just being transfused a lot, but maybe this ties into the iron story, that there are more cardiac events, diabetes because the pancreas isn't functioning normally because of iron overload, liver disease because of iron deposition in the liver. But they also looked at these conditions in MDS patients and looking specifically at those who were transfusion dependent, shown in the purple here, and those who weren't transfusion dependent. And pretty much, for each type of side effect or event, the events were higher in patients who were transfusion dependent versus those who were not. So more cardiac events, more diabetes, more infection complications. So the issue is, is this due to the iron story, or is this really, just that transfusion-dependent patients are in some ways sicker than patients who aren't? Don't know. This is the last data set. So the question also has come up as to whether iron overload, as determined by baseline ferritin levels, have any impact on transplant outcomes. And this was an analysis from the group at the Dana-Farber from a few years ago. And this doesn't project very well, but the idea is that even with bone marrow transplant, patients who had the lowest levels of ferritin going into the transplant seemed to do much better than patients who had the very highest levels. And in terms of complications from the transplant, patients with, again, lowest levels of ferritin seem to have fewer complications than the highest levels. So this is my last slide. So basically, the issue is, to what extent is iron overload really critical in terms of the outcomes with MDS? And the conundrum is, whether iron itself adversely affects survival, or whether iron overload is just a so-called biomarker for MDS patients who have more severe disease. And I think this is sort of an unresolved question, even among MDS experts, I would say. And so I think we should segue at this point to Dr. Pemberton's talk, and he's going to hopefully resolve this conundrum, but maybe address, the data as it is in terms of, when we lower iron and reverse iron overload with medications, does that change the outcome or affect some of these organ function issues? So I don't know if anyone has questions about my part of the talk.
A couple of questions. The iron overload, is it just with MDS, or is it with anybody that would be transfused? I mean, is it because you're getting so much iron in such a short period of time that your body can't discharge it, or are there other reasons why MDS patients can't, process the extra iron out of their body?
Well, as I said, there's no natural mechanism for getting rid of iron other than just, the 1 to 2 milligrams that you lose normally in the GI tract, unless, menstrual blood loss with women. But there probably, as I said, there is something about the iron cycle that's abnormal in MDS. And I think this gets at this issue of so-called, what we call ineffective erythropoiesis, which is a fancy name for the bone marrow doesn't utilize iron and manufacture red cells appropriately. So there is increased absorption, but I don't know that we fully understand why that is.
If I can just say,
Yeah.
most people get transfusions, get them because they've lost blood from an
Surgery or
ulcer or
something
GI
like that.
tract or a wound or something. So they've lost that iron,
Right.
and they're not getting a net
Well,
gain.
here's another question. I mean, and again, I don't understand the blood at all, but has any attempt ever been made to, or would it be possible to actually chelate the iron out of the blood before you transfuse it?
Yeah, that's a good question. I mean, I think red cells without iron are not going to function normally.
So
in
all
other
the
words,
iron
you're-
in the blood is actually contained within the cell.
Pretty much.
Right, okay.
Yeah. I mean, obviously, there's a lot of interest in developing synthetic blood substitutes. I guess the military probably takes the lead in this. Wanting to have something at the battlefield, I guess, that you can use instead of having donated blood bank blood. But I don't think we're anywhere close to having those yet. So there are other chronic anemias where people are chronically transfused. I mentioned aplastic anemia, and obviously the thalassemia, the kids with thalassemia, and they all get iron overload. Yeah.
You study ferritin levels and iron ratios. How does that relate to the study of hemochromatosis or problems from iron, excess iron?
Yeah. So it turns out ferritin is a so-called acute phase reactant. So it's a protein that actually can become elevated under a number of circumstances, not just iron overload. Patients who have chronic inflammation, something like rheumatoid arthritis or a chronic infection, often have very high ferritin levels. But it turns out their serum iron levels are actually low. And often they're transferrin saturations are low. So we try to figure this out based on the algorithms. You know, if the ferritin's high, but the iron's low, probably not iron overload. But if the transferrin saturation is high and the ferritin's high, that's what triggers the thinking about, you know, gee, could this be hemochromatosis? So I think most of us use saturation of 50% and ferritin greater than 700 or so as a reason to consider genetic testing for hemochromatosis. And because it's a pretty common condition, there probably are patients out there who have both MDS and hemochromatosis. But the issue is, for hemochromatosis, the way to treat the iron overload is to, as you say, to bleed the patient. And that's a nice way, you know, with each unit that you donate to the Red Cross, you know, you can take off 200 to 250 milligrams of iron. So, you know, if you do that, you know, a couple times a week, bring your ferritin level down, you know, and if you're not anemic to start with, and your marrow is able to make up and compensate, you're actually able to get rid of iron pretty well that way.
My doctor threw away the iron he took, the blood he took from me.
Because I guess they were concerned about MDS, and probably the Red Cross and other blood centers, you know, have a restriction in terms of using donated units from patients who may have MDS, I'm assuming.
Thank you.
All right, we will transition then. Sure.
Okay, so my name's Cliff Pemberton. I'm at Lankenau Hospital, which is nearby here. And I've been in practice since 1983, doing mostly hematology, and so I've seen a fair number of MDS patients during that time. And I'll start off by saying that the last question that Dr. Millenson put on the slide there, I'm probably not going to answer for you, because it hasn't been answered yet. Okay, so I want to talk about a number of things. Given that somebody has iron overload, what do we have to deal with it? How well do they work? What about side effects? Does it really accomplish anything other than lowering the ferritin level, which is a laboratory value? Given that you can do that, does it really help patients with MDS to have their ferritin level lowered? Which is a real question. And then I'm going to end up with the current recommendations from the NCCN. So this is the only slide which we're going to duplicate. This is the IPSS. I made this slide, so it's not nearly as nice as the one you saw before. But the main thing is, first of all, two things. This group here, where you have 21 to 30% blasts in your bone marrow, is no longer MDS. Since the IPSS was made, that category has been changed to acute leukemia, because almost everybody who had that many blasts in their bone marrow converted to acute leukemia. So nobody gets 2 points anymore, which is right there. And we're going to be talking primarily about the low and intermediate 1 groups. That is, people who have either 0 or up to 1 point in this, because as your disease gets to be higher risk, and therefore in general more aggressive, the effects of the disease far outweigh the risk of iron overload, which takes many months and years to develop. So it makes sense that the group we're going to be concerned about are people who have low-grade MDS, which may smolder for years or be transfused for years, who have time to develop iron overload and also have time to treat the iron overload, which does not take a matter of just a couple of weeks. It's an ongoing process. So that's why almost, as you'll see, the trials that have been done in this and the studies primarily address that group. So there are a number of treatments, and they're all listed here. One is phlebotomy. Second is something called Desferal, or deferoxamine. Third is deferocerox or Exjade. And fourth is another oral iron chelator, which is not available in the United States. So we're not going to talk about that at all. We already
Why
touched...
isn't it available?
The FDA hasn't approved it. Europe does approve it. I don't know why that is. Do you know?
Sounds like it could be an antitrust issue.
Yeah, I honestly don't know.
We are here in the law offices of
lawyer
Pepper
talking.
Hamilton.
Somebody
I
in
don't
the
know why.
FDA likes the company that makes Exjade.
But anyhow, we already touched on the issue of phlebotomy for hereditary hemochromatosis. You stick out your arm once or twice a week, you take off the blood, your bone marrow makes new cells, you're fine, it's very effective. But if you're already anemic and you can't make new red blood cells, it obviously is not going to work. What will happen is exactly what happened to you, is your blood count will go down and won't come back up. Phlebotomy is out, and we are left with really two effective agents, deferoxamine, which does not come in an oral form. It's an injection, and that's why it's less often used now, and Exjade. Deferocerox or Exjade, 2 molecules of Exjade bind 1 molecule or 1 atom of iron. They're tablets. Some of you are obviously familiar with it. Taken on an empty stomach. They come in different sizes. The tablet has to be thoroughly dissolved. In fact, the company makes a neat little mixer thing you can put your tablet in if you want to use that. It has a starting dose and then an adjustable dose. And when I'm going to be talking here about cost and how much iron you can bind, remember that it is different for different people because some people require a higher dose because of their ferritin levels than others. Deferoxamine is subcutaneous. It is actually a byproduct of a bacteria. Bacteria require iron for growth. They like iron, which is a problem, as we'll see. So it binds iron 1-to-1 in the bloodstream. Nowadays it's given, if you use it, where it's like a little beeper. You have a little IV line that goes under your shirt and a little needle that goes into the stomach fat. And it just pumps away. Most people do it at night for 8 to 12 hours. You can do it continually. It's very similar to brittle diabetics who wear insulin pumps all the time and they come to work and nobody would know it. And it has a usual dose which is written there. So getting back to this issue that we touched on before, and these are my calculations, but you know, if you figure that you get 200 or 250 milligrams of iron per unit, you can't get rid of that. Actually, people have tried to minimize iron overload giving a dose of deferoxamine along with a blood transfusion. It's fairly ineffective. It doesn't bind that much, has a very short half-life. So if you get 2 units every 2 weeks, that means in a year you get about 12 grams of iron. And if you get 2 units a month, you get half that, about 6 grams of iron. And our iron loss, we already pointed out, is about 1 to 2 milligrams per day. And that's it. Unless you have bleeding, that's it. You can't adjust. So that comes out to about 0.5 gram a year. So it's quite clear that if you're on regular transfusions, you can't help but accumulate substantial amounts of iron. So how well do these things do? So a deferoxamine or desferal infusion for most people gets out around 30 milligrams of iron overnight. It obviously depends on the concentration. It depends on how long you do it. If you do it all 24 hours a day, you might get 100 milligrams out. These costs are very approximate. They're probably a little bit old, the figures, but the cost of these drugs are considerable, $50,000 a year. Obviously depends on dose and duration, etc. Exjade will usually get out 20 to 30 milligrams per day. That's at the lower dosing, the starting dose. And the dose can be adjusted up if you need to get more iron out. You're not doing it as well as we want. And again, that's about somewhere around $60,000 a year. These are not cheap drugs. So you figure out if, I'm just taking the figure on either one of these, say you get 25 milligrams of iron chelated on either treatment for each day, that's about a little over 9 grams a year, which compares very favorably with 2 units a month. But if you're on a higher transfusion requirement, you're going to need more to do that. And that's where you use higher doses of Exjade or a higher dose of deferoxamine. What about the potential side effects? Because I don't think there's any drug that doesn't have any side effects. So one is this interesting problem of iron and bacterial infections with the infusional deferoxamine or Desferal. There is a higher risk of infection, particularly a bacteria called Yersinia and a fungus called Mucor, which is a very nasty infection. They're quite uncommon, but it is a substantially higher rate than in the general population. And it's interesting that in banked blood that you get from the blood bank, although the rate of infection of those units is very low, the leader among the bacteria is Yersinia because of all the iron in the bank blood. The other side effects, Exjade, which is ferrocirox, got what's called a black box warning, and it literally is, if you look at the package insert, there is a big black box with bold-faced print in it which lists potential risks. In this case, renal or kidney failure, hepatic or liver failure, and GI hemorrhage. A low incidence. This drug wouldn't be on the market if it happened to 10% of people, but it is something that has to be monitored, so that got a black box warning. Some of you may be familiar, it isn't an easy medicine to take for everybody. Kind of the non-specific GI symptoms. Skin rash can be a problem, and cost is a side effect, and it can be a big side effect depending on your insurance coverage. Desferal, the injectable, there are concerns about hearing problems, changes in vision, such that people who are older or who have pre-existing problems have to have screening and ongoing monitoring. Because you're sticking a needle in yourself, you have to worry about reactions there. It's slightly irritating, but you don't want to get an infection. Kidney problems, not necessarily dialysis, but it can affect kidney function. And there's an issue of heart dysfunction if you mobilize large amounts of iron by also taking high-dose vitamin C. Again, an infrequent thing, but something you have to be aware of, and the cost. So can chelation really, I should really have titled this, can it really help the organs? If you bind the iron, you get rid of it, does it really help organ function? And the answer to that is unequivocally yes. And where this has been shown is hemochromatosis and the thalassemias. And the thalassemias, as we pointed out, that's somebody who has lifelong transfusion dependence. So, starting at age 1, getting transfused, you're going to run into big troubles by the time you're a teenager unless you address it. And there's no question that iron chelation can not only improve but also basically almost normalize heart function if somebody has heart failure from iron overload. This has only been demonstrated to a very modest degree in myelodysplasia. And we're going to go through the evidence that we have thus far. And in EPIC is a trial, which I'm going to touch on, which was done about iron overload and myelodysplasia. And there were some EKG changes which were improved. But of course, the question we're going to grapple with is, so what? Does that make a difference in how long people can live? Does that really make a big clinical difference? So in looking at this, probably the first interesting report on this was at the American Society of Hematology meetings in December of 2006. This was reported from a group in British Columbia who looked retrospectively at 170 patients. So this wasn't a prospective trial. They're just saying, okay, let's look at the last 5 years. Here are 170 patients. How'd they do? Those with ICT is iron chelation therapy. So those who got iron chelation had better outcomes than those who didn't. Almost twice the 4-year survival. Now there they were using desferal infusions, 12 hours a day, 5 days a week. It really doesn't matter what they were using. All of their patients who got the chelation, as it turns out, were lower intermediate risk. So they said this is the first data documenting improvement in clinical outcome, which is true, but here it's a retrospective study. So the big question is, why were those patients who got chelation selected for chelation and the others weren't? Was it because their doc said, hey, you're just smoldering along, you look like you're going to have a better survival, and therefore we're going to worry about iron overload, and the fellow on the other side of the room is doing terribly, I don't care what his iron is, that's not his problem. And that is a very important point about a number of the studies in MDS. There were 2 trials in the US, 02 and 03, which definitely showed that in, again, low-risk patients treated with, this is XJade, that their iron parameters did decrease, so it does work in getting iron out. And then in the US 03 and EPIC, a lot of the trials, they've got a nice name which stands for something that was evaluation of patients' iron chelation. It was done with XJade. Did show a decrease in these iron parameters, but of importance is there was a very high withdrawal rate, not just due to side effects of the drug, but also to other factors, but almost half the patients in both those studies had to withdraw before the final end of the study because of some ill effect, and about a third had a worsening of their kidney function. We're not talking dialysis or anything, but there was a price to pay as far as kidney function in a third of those. In 2008, the Mayo Clinic did again a retrospective review of 126 patients with sideroblastic anemia, refractory anemia with ring sideroblasts. They found a couple things. That IPSS worked. That's highly predictive of survival. They found that your requirement for red cell transfusions at diagnosis, that is, whether you were requiring transfusion when the diagnosis was made or not, was independently correlated with survival. But they found that the serum ferritin, with a peak ferritin, made no difference as far as survival.
Could you clarify that the RBC requirement diagnosis independently associated with survival? What exactly do you mean by that?
So if they look back and when people were diagnosed,
Right.
which might be 5 years after they really developed it, when they were diagnosed, whether or not they were receiving red cell transfusions.
At that time?
At that time.
So in other words,
Not later on, not with
as soon as you
fluid.
got diagnosed, you needed transfusions right away?
Right.
Okay. No.
Right. So their conclusion was that that current study did not support the contention that transfusional hemosiderosis, as marked by a serum ferritin, is an adverse prognostic factor in good risk MDS.
But let's parse that. The current study does not support the trans. What's hemosiderosis?
I'm sorry, hemosiderosis is another word for iron overload
Thank you.
due to
No,
transfusion.
no,
I'm quoting them, so that's what they say.
Okay.
That's medical-ese. And they're basing it on the fact that the ferritin level in that study didn't seem to make any difference. Dr. Teferi, who's at the Mayo Clinic and is a well-known hematologist in the journal Leukemia, pointed out that it's often overlooked that the need for transfusion in low-risk patients is associated with inferior overall survival and leukemia-free survival. And what he's taking from that is that an early death from the disease comes from the disease, not necessarily the effects of transfusion. And he went on to say, and this is in the age of XJade, that the mere fact that a chelator, like XJade, has an easier route of administration, i.e. as a pill, doesn't justify its use given the fact that it has toxicity and is very expensive. So you begin to see that there are two sides to this coin, which we'd like to settle. The NCCN.
I'm sorry, could you flip that back? I didn't absorb that last statement there.
So he's saying
The
that.
fact that a chelator has an easier route of administration does not justify use. So what, that is saying that the XJ or a chelating agent isn't really a benefit?
No, he's saying that just the fact that it has an easier route.
Right,
Okay, we know that it does decrease ferritin.
right,
And so people who might have balked at doing a subcutaneous infusion all night, and the doc says, well, we have this pill, so just take the pill, says that just because it's easier to do doesn't mean it's justified.
right.
Basically, looking for proof that it really has a benefit outside of laboratory values.
Where I'm confused, and maybe it's premature to talk about it, but if you're like me, 14 years of transfusions, and you never did chelation therapy at all, wouldn't I have such a high level of iron in me that that would have, by this point, killed me?
In your case, probably so, because you've had a lot of transfusions and would have had a lot of iron.
Yeah.
But again, we're looking at a group here. All these things that, when you boil it down to an individual, there are exceptions, and that's why a doc doesn't
So if a person's
sit.
getting it once a month or once every 6 weeks, you would say that may not be even necessary, really.
Yeah, I think your question is, what's the chance of premature death because of iron by itself?
Right,
Right.
right.
And that's the thing that we're having a hard time answering based on the data such as it is.
Oh, so it's just one more thing with this disease
Yeah.
that you can't answer.
Right.
They're never going to give you an answer.
Yes, scoop me. No, wait a minute. We'll get to that. Okay. So anyhow, in March of 2010, so 2 years ago, the NCCN, which is a highly respected, it's something that a lot of physicians turn to for advice, basically pointed out that at that time there were no studies that prospectively, that is looking at it in advance, documented any clinical benefit of iron chelation. There were retrospective studies, but again, the question comes up, why did those patients, why were they selected for chelation and not the others? You get all these, it's not a random choice. To try and answer that, there is now this thing called the Telesto trial. This is a multi-center, randomized, double-blind, placebo-controlled clinical trial. So, basically, you take either XJade or a pill that looks exactly like XJade, but is a placebo. It's a sugar pill. You don't know what one you're taking, and the doctor doesn't know which one you're taking. Somebody at a central office has a code which is locked in a safe, which can tell you which one you're taking. But the patient and the doctor don't know, so it's totally, that's called double blind. And that's the best way to do these studies. To see whether really it is of clinical benefit. And I have to, when I was looking at this, and this is just an aside, I looked at Telesto, and you know how EPIC stood for something, and I thought Telesto must be transfusion, XJ, you know, what is it? Well, it turns out that Telesto was the daughter of a mythical Greek sea god, Tethys and the Titan Oceanus, and in classical Greek can be referred to as success. And it also was a small body orbiting the moon of Saturn. So who these people are who make up these names, I don't know, but you can learn all sorts of things on a Saturday morning.
This test is restricted to people with transfusion.
I'll show you. So the trial, which is ongoing, in order to be eligible, you have to be over 18. You have to be in that good risk group, low or intermediate 1 risk. You have to have had transfusion requirement for less than 3 years. I'm not sure why they selected that, but they don't want people who are way, way, way out, I guess. But so you have to have it, but not for too long. And you have to have had anywhere from 20 to 75 units transfused and require a fairly brisk, that's about every 6 weeks transfusion, a reasonably brisk transfusion requirement. You can't have been chelated before. Your ferritin has to be in a range where you want to do it, greater than 1,000, and you have to have good renal, hepatic, and cardiac function, and that's, again, that black box warning. They're not going to take somebody who has a very bad heart and ignore the black box and put them on XJ. And it's randomized 1-to-1. You either get the sugar pill or you get XJ. And you won't know which one, the physician won't know which one, and you can do it for up to 5 years, depending on how everything goes. This is an international trial. There are 6 U.S. centers. The closest one here is in Hackensack.
Can I ask a question?
Yeah.
Is what you're, just like summarizes, is this just saying, as far as you know now, you think chelation helps low-risk patients, but you're really not sure, and that's what the study's trying to prove?
That's what the study's trying to prove.
So all along, even though we're chelating, we don't really know if it's what's helping us.
That is correct.
Okay.
But you're hedging your bets.
Right.
But we do
Yes,
know
you
by
are.
chelating with XJ, you are depleting your iron.
No question about that.
Okay, so we know
No
the
question
result.
about that. And you are, if you had iron overload in the heart, you are probably improving that. But does that matter? That's the question. So here's the question. Given that high ferritin levels are
That
bad,
statement's just confusing the hell out of me. Iron overload's a bad thing.
We think.
it is. So is
Wait a minute,
myelodysplasia.
let me
Yeah.
rephrase that. Do we know that iron overload's a bad thing? That's a given?
Yes.
So anything you can do to reduce it or level the impact, gotta be a good thing, right?
Well, you're also dealing with myelodysplasia, which is a bad thing.
Right.
Does that overweigh? In other words, is the myelodysplasia going to be the limiting factor, or is it going to be the iron overload?
Cause and effect.
Okay? In other words, your cholesterol is 230 and you have acute leukemia. Everybody would agree, so what if your cholesterol is 230? It's a bad thing, but you have acute leukemia. Who cares what your cholesterol is? You got to get to 3 weeks from now. That's an exaggeration of what we're dealing with here. So, I mean, this is the question. High ferritin levels are bad. Transfusion burden is a bad thing. Is this due to the iron itself, or is it just that these are markers of an inherently bad disease which requires more transfusions?
It just seems to me that high ferritin levels are a marker that you have an easier disease, a low-risk disease.
Which is why we don't really pursue this question as much with people who have very, high risk scores.
Right. Like if somebody comes in and it's very high-risk score, you don't even talk about it, chelation. But everybody here who's doing chelation is IPSS low,
Right.
or intermediate.
Right. So, when in doubt, turn to the NCCN. Sorry about this. Because they will guide you. So we turned to the NCCN and they said, basically, if you read between the lines, we don't know. Because they use the word consider. So if you've gotten lots of transfusion, you can consider daily chelation, which is true. You wouldn't be reading that if you hadn't considered it already. Particularly for low and intermediate patients. If you're going to do it, you ought to aim to get the ferritin less than 1,000 and really chelate it. Having said that, it's my personal gist that most people who have good risk MDS patients do watch their iron and do recommend chelation. But if you get right down to it, at the present time, to prove that that's really of benefit to that group in general is still lacking. And that's why the Telesto trial is there. And from my point of view, if somebody had some significant reason why they couldn't tolerate Desferal or XJ, it wouldn't be the end of the world. You may not be harming them by omitting chelation. You just don't know right now. And that's where it is. And that's very frustrating. But there we are. So I said I wasn't going to answer the question, and I didn't answer the question.
At least you kept that promise.
Yeah.
But if you think you're going to live a long time, you probably should be thinking iron
Yes.
chelation.
Yeah. Yeah, I mean, I think you always ought to consider it. And then you get down to nitty-gritty things, insurance coverage is one. But I think certainly if somebody looks as though they're going to be doing well for a period of time, that's what I say, I would do it. I mean, I think you're doing the right thing.
Yeah, but if it wasn't for medical insurance, most of us would probably be living in cardboard boxes on the side of the road. So, I mean, XJ is incredibly expensive. You don't have the resource available. I mean, is there any other option?
Is there any natural ways of getting rid of
We're
iron?
trying to get rid of it anyway.
Not that I'm aware of. This is it. I
I mean,
mean,
medical
sticking out your arm, but you can't stick out your arm. That doesn't, that won't work unless...
Yeah, I think, the drugs like erythropoietin, EPO, and Aranesp, I think you do mobilize some of the iron if you respond well to those drugs. And even for patients who, respond somewhat, but they're still transfusion dependent on some level, well, they're less transfusion dependent if they respond to the EPO. So I do think it does sort of temper the iron overload a little bit if you're on those drugs. But, obviously if you're not responding because the MDS won't allow you to respond, then that's not an option.
So if you're making red blood cells from EPO, you are using iron.
Is there any danger?
Yeah, but it stays in your body.
Well, that's true.
Yeah, but it's in the red cells. It's not in
It's not in
the
your
heart.
liver.
It's not in the liver. It's redistributing.
You're not putting new iron in as much
Right,
if
and
you
that's-
are having the EPO work.
The process of chelation, the X-ray jug breaks the bonds where it's stored in the organ and pulls it out. Is that how this works?
It basically binds it in the bloodstream. And therefore you essentially ultimately leach it out from the organs.
Okay, so it's drawing it out.
Yeah.
So it's a molecular reaction.
With the XJ, the XJ is the one, that's the 2-to-1.
Two molecules.
Yeah. Bind an atom of iron. And then once they're together, that can be excreted.
Okay. So
Well, then all you have to do is put 4 or 5 XJ tablets in the unit of blood before you give it to us, and everything's good, right?
That'll get rid of the iron in the plasma, but the red cells all have the iron bound in the hemoglobin. And when the red cells obviously get broken up, otherwise the transfusion would last forever.
Right.
And when they get broken up, that iron is released into your body, and then...
when you read the XJ, taking the oral, it says water or orange juice. In the last MDS meeting we had, it was late using cranberry juice. And I called the XJ, whatever the group is, and they said, no, just stay with orange juice or water.
Or apple juice, didn't they say
No,
apple juice?
they
on
said
it?
apple juice at the MDS, but not the drug company. He said, the pharmacist said, stay with orange juice and
Okay.
water.
Doesn't orange juice help you retain iron?
That's what-
Vitamin C will help with iron mobilization, helps with iron absorption, actually.
Yeah, it's a cofactor for absorbing iron from the GI.
So you're kind of working against it, but you think the numbers are small.
It's a trivial amount.
Well, I mean, but water doesn't do that, so...
Yeah, but you never took XJ with water.
No, I haven't.
Otherwise, it's just straight chalk.
Yeah, I mean, it's inedible.
Well, it's
All
better
your
be doing a
doctors
shot
should
class.
have to do that.
Yeah.
Yeah, did you hear what Frank said?
What's that?
All doctors should have to taste XJ before they recommend it.
And after a bone marrow biopsy.
Yeah.
So orange juice then is contradictive to the way it works.
Except not in amounts. The
Well,
amount that the orange juice is keeping the iron in you is so
Right.
small compared to the amount that...
but if you want to get the greatest benefit, but I
But
don't.
I'm not doing water.
I'm not sure.
I'm Tropicana's best
Yes.
customer.
I'm right behind.
You don't swallow the pill, you grind it?
No, it has to be dissolved in a liquid.
Oh,
In fact, they do make like those little coffee grinders, and then XJ makes one.
They actually do.
I just.
I used to do that. I put the pills inside a coffee grinder.
Yeah.
Actually, the best is when I get up in the morning, I take the pills, put them in the glass, I put a ½ inch of water in it, take my shower, come back, add orange juice, and it's all dissolved.
Yeah.
You don't have to beat that. I mean, it's like beating stones.
I do it at night.
You do it at
I
night.
put it in orange juice at night. When I come down in the morning, it's the first thing that I have. It's all, I don't have to wait around for it to...
Mhm.
The Exajade makes me so
Okay,
tired
taste.
lately. My husband says, well, take it every other day. But
Why do you think it's the Exjade that's making you tired instead
Because-
of the disease itself?
well, it's a worry, you know, am I getting worse? Is it the medicine? So I stopped taking it on Tuesday, and I just seem to feel better.
Yeah, I
So
feel
maybe it's all
like-
my head, but, you know, the XJ makes my whole head feel like I'm having a hot flash. You've never had a hot flash,
No.
but,
I'm getting it.
you know, your head feels swollen.
Hmm.
And it's right after I get a transfusion, it's not when I need one. So I don't think it's the need for the blood that's causing it, you know, and these come and go periodically.
What I've found is something you just said, that when I used to get transfused, I'll never forget my first transfusion, and then I thought I was better. And,
Cured?
you know, I felt so great that I told my siblings, don't worry about getting tested for bone marrow, because I'm better. And then, I mean, that's how great a difference it was. Now, there's no difference at all in getting transfused. So
How
a
do you
very
feel?
small difference. I could be really run down, but I don't feel so much greater when,
I don't either. It takes sometimes 3 days, and then I start feeling better. And
Yeah, I have a little dip and then I come back up. I think everybody
I
reacts.
feel tired every day of the week.
well, with all that Exajade you're taking, you take a lot.
But I don't think it's XJ. There's nothing that said to me that I'm tired because
How
of the
much do you
XJ.
take? I take 1,000 and I'm tired.
I take 2,500
Yeah, no
a
wonder.
day.
What do you
But
mean
I don't
by that?
have the sense that it's the XJ. Nothing in me says
No?
that's what's causing it. What's causing it is that I'm not getting much higher than 9.5 out of my transfusions. I'm transfused at 7.5. So I come out at 9.5. So I'm always down in the lower numbers.
Well, I can definitely tell the difference in Fran when she's at 9 and when she's below 8.
No,
I mean, everything about her changes. Her complexion changes, her attitude about the disease changes. You get new blood, and you know I mean, when's the last time you've been over 9? I mean, 9 is what we shoot for. And
I guess it
that's
might
good.
go above that, but they don't, who wants to get a
They'll do right
blood
after,
check in
right.
the middle of the 2 weeks?
right. Well, I don't disagree with you, that you feel better at 9 than you do at 7.5. And I just find that I don't get the kick that I used to get from transfusions. It's not a terrible thing, it's just that I'm still tired 2 days after I had a transfusion. I still sleep until 11 o'clock. And
I find that I sleep a lot too. Come home from work and take a 2-hour nap, and then I go to bed 2 hours later and I sleep all night. No trouble sleeping.
Can I ask you to go back to that first slide you had? You had something on there I thought was interesting.
First
The
slide.
very first slide, the one you made.
Okay.
I think
A real ugly looking one.
Yeah.
Cartoon?
This one?
Yes. On the bottom there, you have good, normal line, 5Q, 20Q.
Okay.
Is
So,
that the progression, or?
no, that's karyotype is the chromosomal analysis. And of the chromosome, you can have normal chromosomes. You can be missing the Y chromosome, which is the male chromosome. This is in the blood cells. You can be missing the short arm of the 5th chromosome, which
In
is
the blood cells?
in the blood cells.
Okay.
So when you
In
have
the
a
bone
bone
marrow,
marrow done,
right.
there's usually a chromosome analysis done on that, which would be different than if we took a muscle cell,
Right.
which would presumably be normal. And poor karyotype is if you have 3 or more abnormalities,
Oh, of those 3, of the ones on the
any
right?
3,
Okay.
just 3, you know, it's really messed up, or anything to do with chromosome 7. And then intermediate is everything else.
Okay, I understand.
So in other words, there's some good chromosomal changes that 5q minus, I can't put the thing, there it is, responds very nicely to a drug called lenalidomide. It's a pill and very often get a very nice,
Yeah, I'm missing 20.
okay, well that according to this is a good thing.
Yeah, no, that's what they said.
Yeah.
What the hell does that mean? I looked at the slides and it's like reading tea
Well,
leaves.
you know, this is a prognostic score and it is not a